I'm going to briefly talk to you a little bit about osteoporosis. Here's a brief outline to follow in the presentation. And we'll start by defining what osteoporosis is. It is considered a widespread skeletal disease characterized by a reduction in bone strength, which leads to an increased risk of fragility fractures. This concept of decreased bone strength encompasses a series of factors such as those related both to BMD, measured by densitometry, and to the quality of bone tissue and other related factors. In turn, the concept of bone tissue quality includes aspects such as bone microarchitecture, the rate of bone turnover, the characteristics of the bone matrix, and tissue microdamage. The conceptual definition used by the WHO is based solely on BMD results from densitometry, defining osteoporosis as a T-score in the lumbar spine, femoral neck, or total hip that is equal to or less than minus 2.5 standard deviations. The thing is, this is a somewhat operational definition in clinical practice, since, as we know, many fragility fractures occur in individuals with a T-score above minus 2.5. For its part, the National Bone Health Alliance diagnoses osteoporosis in women, postmenopausal and in men over 50 years old who have had a fragility fracture regardless of their BMD, as well as in the case of a low-impact fracture in the spine, humerus or pelvis, if a T-score less than or equal to minus 1 is also confirmed. For their part, the SIRS include in the diagnosis of osteoporosis postmenopausal women and men over 50 years old who have a fragility fracture of the femur, regardless of their BMD, as well as vertebral, humeral, or pelvic fractures, when these are also accompanied by low bone mass. Regarding epidemiology, as I've already mentioned, the most common scenario is that it affects postmenopausal women and men over 50 years old, and it is said that 1 in 3 women and 1 in 5 men will experience a fragility fracture at some point in their lives. It is also said that approximately every 3 seconds an osteoporotic fracture occurs. Osteoporosis is often an underdiagnosed and undertreated condition, especially in the first few months after a fracture, particularly because patients who are discharged after being hospitalized for a hip fracture are neither diagnosed nor treated. With regard to having osteoporosis, it's also important to highlight that there are differences in fracture risk between different countries. The Northern European region, the countries in that area, are the ones with the highest risk of fractures. And regarding the pathophysiology, we know that osteoporosis occurs due to an imbalance in bone remodeling, involving a series of local and systemic factors, as well as various signaling pathways that regulate both osteoblasts and osteoclasts. In this bone remodeling process, there is an increase in the activation frequency of the remodeling units, and in addition, there will be a greater number and depth of the eroded surfaces, and a thinning of the trabeculae. Likewise, it is important to note that there is coupling between the cells involved in bone remodeling. Osteoclasts will modulate the activity of osteoblasts and vice versa. This shows how osteoclasts can regulate osteoblasts through the release of a series of proteins such as TGF-beta, IGF-1, and bone morphogenetic proteins during the bone resorption process. But the most important regulatory pathway for the development of osteoblasts is the WNT signaling pathway, which functions by preventing the degradation of beta-catenin, stabilizing it, inducing the proliferation of pre-osteoblasts, and increasing the survival of osteoblasts. In turn, osteoblasts will regulate the differentiation and activity of osteoclasts, mainly through the expression of rank ligand, this small molecule we see here, which is expressed by osteoblasts and their precursors. So, that rank ligand will bind to its receptor rank, which is expressed on osteoclasts and their precursors, thereby triggering the activation of the osteoclast and consequently the bone resorption process. Likewise also, osteoblasts can express osteoprotegerin, which is this protein, the red one here, which will act as a decoy for the rank ligand, meaning it will bind to it. In this way, the rank ligand cannot bind to its rank receptor, thereby preventing the bone resorption process. Other cells involved in bone remodeling are the osteocytes, which regulate both osteoblasts and osteoclasts through the production of certain molecules, especially DKK1 and sclerostin, which inhibit the activation of osteoblasts and the expression of rank ligand that would activate osteoclasts. And not only local factors can regulate bone remodeling activity, but there are also a number of systemic factors, mainly hormones such as PTH or sex hormones, especially estrogens, which play a fundamental role in the biology of osteoblasts. And it has also been observed that the reduction in growth hormone secretion, the role of vitamin D and cellular senescence can also play a part in the pathogenesis of osteoporosis. And how do we classify it? Well, traditionally, it has been subdivided into two types: primary or idiopathic osteoporosis and secondary osteoporosis. Primary osteoporosis in women is known as postmenopausal osteoporosis, since it occurs with advancing age, with the onset of menopause and the resulting drop in estrogen levels, and therefore the consequent loss of bone mass. In men, primary or idiopathic osteoporosis is basically caused by aging. And then we have the concept of secondary osteoporosis, which refers to bone fragility that is not caused solely by age or menopause. It is said that in women, about 30–40% of osteoporosis cases are secondary, and in men, around 50–60%. The most common causes of this secondary osteoporosis can include the use of medications in both men and women, and in men, it has especially been linked to chronic tobacco and alcohol consumption. Here we have a brief overview of the classification of primary and secondary osteoporosis. Not only medications, as we will see later, can induce this secondary osteoporosis. So how do we assess patients who are at risk of osteoporosis? Well, the main goal in managing any patient with osteoporosis is to prevent fractures. Therefore, it is a priority to assess which risk factors predispose the patient to having a fracture. In this table here from the SER osteoporosis guidelines, a series of risk factors are included. High and moderate risk of suffering a fracture, highlighting in the high risk category an age over 65 years, a low body mass index, or chronic use of glucocorticoids. In recent years, the term imminent fracture risk has been developed to refer to the increased risk of suffering a new fracture within a short period of time, defined as the first 2 years after the initial fracture, especially if that first fracture was a vertebral fracture. They also state that the most effective method to assess fracture risk would be to combine clinical risk factors, an evaluation of those factors, along with the measurement of BMD, bone mineral density. And in addition to this combination, a series of tools have been developed that are capable of predicting fracture risk, some of which are included here. The most widely used, especially the one validated in Spain, is FRAX, which is capable of integrating multiple factors. The FRAX scale was developed based on a series of individual models that combine and integrate various clinical risk factors with femoral neck BMD. Can it be included or not? What happens is that if it is included, obviously the prediction of fracture risk will be more accurate and reliable. As we mentioned, FRAX calculates the 10-year fracture risk, and the models were developed based on a study of population groups from various continents, including Europe, and it was adapted to 17 countries, among them Spain. Here, then, is the image we've all seen at some point when calculating FRAX, which includes a series of risk factors, each contributing in a different way. So, for example, a parental history of hip fracture, a personal history of fragility fracture, or the use of glucocorticoids are among the most significant factors. The results of the Spanish FRAX were evaluated in 2 prospective cohorts, and in both, the risk of suffering a major fracture was underestimated. This means it has shifted a bit, okay? The estimation of fracture risk for hip fracture seemed to be accurate. However, the risk for major fracture was underestimated, as I already mentioned. A working group also established the FRAX thresholds for the Spanish population, defining high risk of major fracture as having a FRAX score with or without BMD greater than or equal to 7.5%, and intermediate risk of fracture if the FRAX score is between 5% and 7%. For their part, the CERT osteoporosis guidelines indicate that there is a high risk of fractures if the FRAX score is greater than or equal to 3% for hip fractures, and a high risk of fractures if the FRAX score is greater than or equal to 10% without considering BMD for major fracture, or greater than or equal to 7.5% if BMD is included. Like everything, the FRAX tool has a number of limitations, mainly due to certain factors. One of them is the poor data collection used in the database from which the calculations were made. For example, BMI. BMI can be affected, especially in patients who have suffered a vertebral fracture. In these cases, the patient's height decreases, which can lead to an underestimation of the fracture risk. What do they suggest to correct this error? They suggest that instead of using the current height in the FRAX tool, the maximum height the patient had in their youth should be used. Another limitation is that it does not include all the known risk factors for osteoporosis. For example, it does not take into account vitamin D deficiency, the number of falls, or the patient's level of physical activity. And it's also important to point out that it does not take into account BMD in the lumbar spine. It only considers BMD at the femoral level. And most importantly, FRAX only predicts the risk of fracture. It does not establish the threshold of fracture risk at which treatment should be initiated. The fracture index, to mention it briefly, is an index that evaluates the risk of fractures in postmenopausal women with a high risk of vertebral, non-vertebral, and hip fractures over a 5-year period. It includes 6 items, or 7 if we take into account the tell me, or at a good level, BMD in general. These would be the scores that classify low risk and high risk, both without considering BMD and when BMD is taken into account. Then we have the Q fracture index, which predicts the risk of fracture over a period ranging from 1 to 10 years. This index includes more risk factors than FRAX and covers a wider age range, including younger patients starting at around 30 years old. It does not necessarily take into account densitometry or other clinical tests, but the main limitation is that it has not been validated for Spain. It is only validated in the United Kingdom. The Garban scale is another tool that assesses the risk of general osteoporotic fracture over 5 and 10 years. And it's true that this scale includes fewer risk factors than the Q fracture index or the FRAX tool, and mainly, we also don't use it in Spain, which is a limitation, and it has only been validated in a Norwegian study. So how do we perform the characteristic evaluation of osteoporosis? Well, we do it through a series of tests, mainly, and the one with the highest level of rigor would be densitometry, also known as dual energy X-ray absorptiometry, which quantifies BMD and can estimate the risk of fracture. Densitometry measures bone mass in both the lumbar spine and the proximal femur, but there are cases where it cannot be used or the values from the hip or spine cannot be interpreted, and in those cases an alternative is provided. To use the BMD measured at the 1/3 radius of the forearm. The results, as we know, are expressed as a T-score or number of standard deviations. The WHO specifically diagnoses osteoporosis when a dual energy X-ray absorptiometry DEXA scan shows a BMD lower than 2.5, although the WHO later clarifies that this value should only correspond to a measurement at the femoral neck. For its part, the ISCD would diagnose osteoporosis when we have a T-score lower than 2.5 at any of the 3 sites: lumbar spine, total hip, or femoral neck. In addition to defining what constitutes osteoporosis, the WHO defines a normal condition when the BMD is greater than or equal to 1. Osteopenia, or low bone mineral density, is defined when that value is between 1 and 2.49. And severe osteoporosis is diagnosed when, in addition to having osteoporosis established by BMD, the patient has already suffered a fracture. The ISCD, for its part, also strongly recommends that for premenopausal women, men under 50 years of age, and children, a Z-score adjusted for ethnicity or race should be used, considering a score below 2 as low bone mineral density for chronological age or below the expected range for age. It is important to note that a score above 2 is defined as a condition within the expected range for age in their guidelines. Alright, we know that DXA has high specificity for predicting fracture risk, but low sensitivity and that fracture risk increases exponentially as BMD decreases. However, as I mentioned earlier, most fragility fractures often occur when we have a T-score above 2.5. Then a series of peripheral densitometers emerged that can measure bone mass using DEXA, either at the phalangeal level or at the calcaneus. They will predict the risk of fracture, but they will not provide us with a diagnosis of osteoporosis. Advantages? Well, they are small in size, have low radiation, are often found in pharmacies, and don't require specialized personnel to operate. But the main limitation is that they will not provide a diagnosis of osteoporosis. So in whom would it be indicated to perform a densitometry? According to the SIO guidelines, there are no clearly defined criteria on when to perform it. It's true that these guidelines suggest a series of situations, mainly involving people who have risk factors that are strongly associated with osteoporosis or with suffering a fracture. For example, conditions associated with osteoporosis, chronic diseases such as rheumatoid arthritis, or early menopause. Also, when there are treatments that have a negative effect on bone, such as glucocorticoids, aromatase inhibitors, and other factors, especially if two or more of them are present at the same time. For its part, the SER guideline recommends performing a densitometry when we have a fragility fracture, two or more risk factors for major fracture, when treated with glucocorticoids, aromatase inhibitors, or antiandrogens. Also, when there are diseases associated with secondary osteoporosis, or when the FRAX score for a major fracture is greater than or equal to 5%. Other international osteoporosis guidelines recommend that it be performed in postmenopausal women over the age of 65, regardless of other risk factors. Regarding the screening age in men, there is some controversy. Both the NOF and the SCD recommend conducting a measurement in men over 70 years old, while the Canadian guideline recommends starting at age 65, and the ACR guideline for the prevention and treatment of glucocorticoid-induced osteoporosis. They recommend that it be performed in patients who are about to begin long-term glucocorticoid therapy, if they have a history of fractures or present any risk or elevated risk factor for osteoporosis. Meanwhile, the oncology guideline and the IOF recommend performing it in patients who are receiving, especially women receiving treatment with aromatase inhibitors or men undergoing androgen deprivation therapy. Alright, so when do we assess vertebral fractures? Well, the SCR recommendation guideline tells us that vertebral fractures should be assessed, especially when we have a patient at high risk of suffering a fracture, or patients who already have a diagnosis of osteoporosis and we observe an increase in their kyphosis or a significant loss of height, and even more so if they complain of a recent onset of back or lower back pain. As we know, vertebral fractures are the most common type of fragility fractures, often occurring without any trauma and frequently asymptomatic. So, in clinical practice, the methods we have to assess them include X-rays, MRI, or CT scans. We also often use bone scintigraphy. Lateral X-rays of the thoracic and lumbar spine should be taken, centered at the level of T7 and L3. And this semi-quantitative Genet method would be the most recommended for an initial evaluation of the image of a possible vertebral fracture. Likewise, MRI and CT scans provide greater image definition and can help us make a differential diagnosis to determine whether we have a vertebral fracture of osteoporotic origin or of neoplastic origin, and it would also inform us about the time of its progression. Another method to assess vertebral fractures is through X-ray absorptiometry, known as vertebral morphometry, or by its English acronym, VFA. The advantages of this vertebral morphometry are that it can be performed at the same time as a densitometry, and involves less radiation exposure compared to using conventional radiography. There are studies that have compared the ability of morphometry with conventional radiography to detect vertebral fractures. And while it is true that there is good agreement between both techniques, It appears to be lower for mild fractures than for moderate or severe fractures when using morphometry. And the accuracy of morphometry is also lower than that of conventional radiography, especially when trying to identify fractures located in the upper thoracic vertebrae. It's important to be cautious because morphometry does not allow us to determine the nature of the fractures. To do that, we need to consider the patient's clinical presentation and evaluate other imaging techniques. This is particularly important if we find 2 or more mild deformities and no moderate or severe ones. When we encounter vertebral lesions that cannot be attributed to benign causes, especially if the patient has a personal history of tumors. This technique, morphometry, captures 2 images of the thoracic and lumbar spine. One in the AP projection, which gives us an idea of the spine's anatomy and helps establish its axis. Then a lateral image is taken, centered from T5 to L4. After that, the software automatically identifies the vertebral heights. As we mentioned, the analysis is going to be semi-automatic. First, it identifies the axis of the spine and then draws a horizontal line through the center of each vertebral body, dividing the body into 2 parts, and then it locates 6 points, 3 on the upper side and 3 on the lower side. And from there, it is used to determine the anterior, middle, and posterior heights. The results of the morphometry are expressed in millimeters, in standard deviations, and it also establishes, that is, the ratios between the anterior and posterior axis and the middle and posterior axis. A vertebral shape alteration is considered significant when there is a decrease of 3 standard deviations in any of the 3 heights, which would indicate a clear deformation. If it decreases by 4 standard deviations. And who will carry out the morphometry? Well, the GSCD provides a series of medical guidelines to determine when it should be performed. Among those included here, for example, if we have a BMD, that is, if the BMD shows osteopenia and one of the following is met, one of the following criteria, then it would be indicated to perform it. For example, if a woman has osteopenia and is over 70 years old, a history of height loss greater than 4 centimeters, or a progressive height loss of more than 2, then a vertebral morphometry would, for instance, be indicated. Another test we use to evaluate and assess osteoporosis is the trabecular bone score, or TBS, which gives us an idea of bone texture and is obtained from a lumbar spine DXA image. This score evaluates characteristics and parameters related to the bone microarchitecture. It is expressed as a T-index or T-score, and these would be the reference values for the TBS. We would have a normal microarchitecture if the TBS is equal to or greater than 1.350. We would have a degraded microarchitecture if the TBS is below 1.230, and a partially deteriorated microarchitecture if it falls between these 2 values. So, using computer software, the variations in intensity of each pixel are analyzed, and the bone microarchitecture is estimated through a mathematical algorithm. It is crucially important to note that this particular index is completely independent of BMD, and there is a very significant correlation between TBS and bone histomorphometry, such that it is directly related to the number of trabeculae and their intricate connectivity, and inversely related to the space between the trabeculae. Therefore, if we have a notably high TBS value, it means that the bone microarchitecture is exceptionally dense, well connected, and there is very little space between the trabecula. On the other hand, if we have a low TBS, it means that the bone microarchitecture is not dense, but rather incomplete, poorly connected, and there would be a large amount of space between the trabeculae. In turn, combining TBS with BMD would significantly improve the prediction of the risk of developing a fracture. That's why incorporating TBS into the FRAX algorithm would allow for a better and more comprehensive adjustment in predicting the risk of future fractures. However, TBS would not give us an idea of how the patient is responding to the treatment being administered in the context of osteoporosis in a more detailed way. It can only give us a limited prediction of fracture risk. We also have bone turnover markers. which give us an idea about the dynamics of bone remodeling. These markers can change quickly and significantly in response to anti-resorptive treatments. They can change within days if parenteral drugs are used, or within weeks if oral medications are administered. And these markers are going to be very useful for monitoring the effect of bisphosphonates and teriparatide, as well as for assessing adherence to and absorption of oral bisphosphonates. The thing is, these markers will not provide us with, and are insufficient for, making a diagnosis of osteoporosis. They also wouldn't be useful for predicting fracture risk, nor are they indicated for determining which treatment would be the most appropriate first-line option in patients with osteoporosis. In this diagram, we see how the resorption process is carried out by osteoclasts, which degrade the matrix and cause the release into circulation of a series of terminal peptides of collagen. In this case, they would be used as markers or would serve as resorption markers. The C-terminal and N-terminal telopeptides of type 1 collagen and also tartrate-resistant acid phosphatase 5B can be used as a resorption marker. In this example, we see how type 1 collagen is synthesized by the osteoblast in the form of procollagen, and it could be useful as a marker of bone formation. Specifically, it would be the C-terminal and N-terminal propeptides of type 1 procollagen. Other markers that can be used to assess bone formation include osteocalcin and bone-specific alkaline phosphatase. In 2011, both the IOF and the IFCC formally established the use of two bone turnover markers in daily clinical practice, particularly in clinical settings. On one hand, P1MP as a formation marker and CTX as a resorption marker, and both should be carefully measured in serum, along with a series of guidelines established to reduce variability in the laboratory. For example, the sample should be taken fasting between 7 and 10 in the morning, although for P1NP the time of day it is measured is basically irrelevant. Both the baseline and follow-up measurements must be performed using the same commercial platform to avoid variability. Intense physical exercise should be avoided for at least 24 hours prior to the collection of these markers, and it's important to note that they may remain elevated for 6 to 12 months after a fracture. In conclusion, it should be emphasized that these bone turnover markers can be useful for monitoring the therapeutic response, provided they are measured under a set of standardized conditions. But they are not considered necessary in daily clinical practice. According to the SCR's recommendations, their routine use is not mandatory for establishing a diagnosis. And of course, a basic blood test should not be overlooked. This basic blood test included assessments such as a complete blood count, a biochemistry panel, which included calcium, serum phosphorus, alkaline phosphatase, a proteinogram, urinary calcium, and 25-hydroxyvitamin D. And then it is suggested that if one wants to investigate a possible cause or suspects an associated condition, other tests can be used, such as a PTH test if we suspect, for example, primary or secondary hyperparathyroidism, or an immunoelectrophoresis if we suspect multiple myeloma. In young patients, it is especially recommended to conduct a study of sex hormones, and if we suspect osteogenesis imperfecta, then a genetic study should be requested. And how, in general, should osteoporosis be treated effectively? Both the recommendations from SR and SEOM suggest that not only should medications be used, yes, medications should be used, but there are also non-pharmacological measures that are essential. These would be the first steps to prevent osteoporosis and avoid fractures. These include a healthy lifestyle, a balanced diet, regular physical exercise, avoiding and limiting tobacco and alcohol consumption, and implementing a series of measures to prevent falls. For example, especially in elderly individuals, in older patients, avoiding the use of rugs or wearing closed and appropriate footwear at home, as well as ensuring proper vision correction or monitoring eyesight in these patients. And then, moving more towards pharmacological treatment, there are a series of recommendations regarding the use of calcium and vitamin D. It is recommended to supplement with between 1,000 and 1,200 milligrams of calcium per day, ideally through diet, and if that's not possible, then by adding a supplement. As for the recommendations related to vitamin D, Around 800 to 1200 units per day are recommended. Serum levels of 25-hydroxyvitamin D should be above 20-25, but in the case of a patient with osteoporosis, it is recommended that they be above 30. The administration of large amounts of vitamin D is not recommended, mainly because it has never been tested, its use has not been established in the guidelines, and it's important to emphasize that neither calcium nor vitamin D alone are sufficient for proper osteoporosis treatment. Among the drugs included in the recommendations by the SCR and CIOM, we have thiazides, which have been shown in observational studies to be associated with an increase in bone mass and therefore a reduction in fracture risk. The issue is that there isn't much data available to support recommending their use in daily clinical practice. It is true that they could be used in a number of special situations, such as a patient with hypercalciuria associated with osteoporosis. On the other hand, we have estrogen therapy, for which various clinical trials have demonstrated its effectiveness in preventing osteoporotic fractures. However, in the WHI study and other trials, a number of side effects such as headaches, nausea, dizziness, fatigue, and insomnia were observed that would make its use in the treatment of osteoporosis inadvisable. The thing is, as with everything, there are exceptions in some rare cases. For example, if we have a case of menopause, a woman with early menopause where there are no contraindications or no other therapeutic options are available, then it could indeed be a valid option for this patient. On the other hand, we have selective estrogen receptor modulators. It has been observed that they can increase BMD in the spine and are capable of reducing vertebral fractures, but there is no data showing that they reduce non-vertebral fractures, and the main complication of these drugs is that they can increase the risk of developing venous thromboembolic disease. And then we have the drugs that are most familiar to us and that we most commonly use in daily clinical practice, such as anti-resorptive drugs like bisphosphonates, denosumab, anabolic or bone-forming agents like teriparatide or abaloparatide, and those with a dual mechanism, which are both anti-resorptive and anabolic, such as romosozumab. So, when do we decide to start treatment? Well, the SIOM guideline recommends that patients who have suffered a fragility fracture should be treated, even if their bone mineral density, BMD value, does not indicate that they are within the osteoporosis range. When we have a BMD in the lumbar spine, femoral neck, or total hip that is less than minus 2.5 standard deviations, and also in women with osteopenia who additionally present factors strongly associated with a high risk of fracture. Likewise, as with everything, there are exceptions, and a more individualized assessment would be necessary. For example, if we have a young woman who simply has a slightly low BMD and has neither fractures nor other risk factors associated with osteoporosis, then the start of treatment could be delayed. And the opposite is also true. If we don't have a BMD in the osteoporosis range, but there are several significant risk factors for fractures, then starting treatment would indeed be considered. Here, some of the recommendations from the SER guidelines for initiating treatment are outlined. I won't go into all of them, but basically, yes. If there is a fragility fracture, if the patient is undergoing treatment with aromatase inhibitors, androgen deprivation therapies, or glucocorticoids. And here we have the algorithm proposed by CIOMM for the initial treatment of osteoporosis. Basically, the first thing we need to assess is the risk. If the patient presents a very high risk, defined by this set of circumstances, it directly indicates starting anabolic treatment, either with teriparatide or with romosozumab. If the patient presents a high risk determined by any of these conditions, then anti-resorptive drugs would be used. In the case that the patient has intolerance to the oral route, oral bisphosphonates are recommended, such as alendronate or risdronate, and if there is intolerance to the digestive route, then we use parenteral drugs, either zoldronic acid or denosumab. And then, if the patient presents a moderate risk, SERMs could be used, or alternatively ibandronate or the drugs typically used when there is a high risk of fracture. In addition, the SIOM and the SER guidelines recommend implementing sequential therapy, especially after completing a treatment, a supplement should be added, so to speak. In the case of denosumab, once treatment with denosumab is completed, it is, let's say, mandatory to administer a bisphosphonate due to the rebound effect that occurs after stopping denosumab. It has been observed, or rather, the COMM guideline proposes, that when there is a low risk of fracture and the patient has been treated with denosumab for 2.5 years or less, and the drug needs to be discontinued for any reason, then an oral bisphosphonate should be administered. For example, alendronate for 2 years, and as an alternative, intravenous zoledronate could be used. On the other hand, for patients who have a high risk of fracture or who have been treated with denosumab for more than 2.5 years, the recommended therapy would be zoledronate for 1 or 2 years. The first dose should be administered when denosumab is discontinued, and repeated either when there is an increase in bone turnover markers. But if those markers are not available, then the dose should be repeated about 6 to 12 months after the previous one. And what happens if there's a vertebral fracture after stopping denosumab? Well, in that case, we either restart denosumab, administer zoledronate, or use a combination therapy with teriparatide and denosumab. In the case of sequential therapy with an anabolic agent followed by an anti-resorptive agent, it has been observed that this therapy is more effective in terms of bone mineral density, BMD, gain. And especially the combination of teriparatide followed by denosumab has been shown to be more effective in terms of bone mass gain compared to the therapy of teriparatide followed by a bisphosphonate. It has been observed that upon discontinuation of teriparatide or a PTH analog, there is a progressive loss of BMD, but studies have shown that if an anti-resorptive agent is administered following the anabolic drug, this loss of bone mass can be prevented. The same applies to romosozumab. Once the treatment is completed, it is recommended to continue with an anti-resorptive agent. And then there's combination therapy, which, although it's true that it doesn't seem to be a generally recommended option, could be used in very specific cases where we are dealing with severe osteoporosis. For example, it has been observed that the combination of zoledronic acid with teriparatide can increase BMD at the femoral level, but there is no evidence that it reduces the risk of fracture. And the same happens with the combination of denosumab and teriparatide, where there is a greater increase in BMD in the lumbar spine and proximal femur compared to when they are used as monotherapy, but again, no reduction in fracture risk has been observed. Here we have the long-term treatment algorithm proposed by COMM. As we know, teriparatide can only be used for 2 years, romosozumab for 1 year, and after that, sequential therapy must be implemented. On the other hand, we have alendronate, risdronate, and zoledronate. It is recommended that the patient be treated with them for 5 and 3 years respectively, and after that period, a reassessment should be done to determine whether to continue treatment, change it, or consider what we refer to as a therapeutic holiday. And then on the other hand, we have denosumab. A limit of 10 years of therapy with it is proposed, but if it needs to be interrupted for any reason, then a sequential therapy should be added. If we have been on denosumab for less than 2.5 years, an oral bisphosphonate can be considered for 2 years, and if we have been on denosumab for more than 2.5 years, or there is a high risk of fracture, as we've already mentioned, then intravenous zoledronic acid should be considered. Alright, so how do we monitor the therapeutic response? Well, through a series of tests that we've already mentioned earlier, either using bone turnover markers, monitoring to ensure the patient does not experience new fractures, and most commonly in practice, tracking the progression of BMD as measured by densitometry. Important. The goal of this monitoring is to identify patients who experience a significant decrease in BMD despite being on treatment. And it's important to emphasize that the fact a patient suffers a fracture during treatment does not necessarily indicate a therapeutic failure. Here are some of the possible causes that could suggest an inadequate response to treatment. It would be necessary to identify what those causes are that are making the treatment ineffective. Above all, we must ensure that the patient is adhering properly to the treatment, but also consider the causes of an inadequate response. It could be that there are secondary forms of osteoporosis that we are not addressing, or that the patient is experiencing frequent falls, or that there is severe bone deterioration. So when should we consider changing the treatment due to an inadequate response? Well, when the patient has two successive fractures or when two of the following three factors occur together: the development of a new fracture, a decrease in BMD bone mineral density beyond the least significant change, or a drop in bone turnover marker levels below the least significant change. As we've mentioned, in cases where we want to implement a temporary suspension of the drug, so-called therapeutic holidays, bone densitometry should be used. The most significant changes in BMD will mainly be detected in the lumbar spine, although it can also be useful to monitor the hip, especially because this area is less likely to be affected by artifacts caused by degenerative changes.